Good day, dear students. In current lecture, we will discuss human bacterial respiratory pathogens. We have several of them, and I want to start with Corynebacterium, which is known as a causative agent of disease diphtheria. Corynebacterium belong to separate family Corynebacteriaceae. We have the only pathogenic for human species, which is Corynebacterium diphtheria, and it is classified into 4 biotypes: gravis, mitis, intermedius, and bilfanti. As you can see in the picture of the center of the slide, bacteria is gram-positive and rod-shaped. And actually, if you will use large magnification, high magnification, or even electron microscope, very often bacteria have a club shape. One or both poles are enlarged, and bacteria have unique appearance. It is non-motile, non-sporing bacteria which have facultative anaerobic respiration, and in clinical samples, it is possible to reveal slim layer or microcapsule. Bacteria have the only species, but we will talk later, it can be pathogenic or even non-pathogenic. And pathogenic Corynebacterium diphtheria is easy to reveal with the help of unique inclusions in the cytoplasm of the cell, which is described by a scientist and named in his honor as Babes Ernst bodies or granules, which is metachromatic volutin by biochemical structure. And usually we have methylene blue staining technique, Loeffler's methylene blue. In Russia, the technique is known as a Naser staining. In India and many number of foreign countries, it is known as the Albert stain. So if you will apply that technique, bacteria vegetative cell will be presented as green or yellowish in microscope, and metachromatic volutin, if it is present, it will be easily identified in one or both poles as a dark blue or brown spherical shaped thing, as you can see in the lowest picture on the slide. And pathogenic species always have contained that inclusion. If bacterial species is not pathogenic, then those inclusions will be absent. And usually it's difficult to describe arrangement of bacteria slide because it's looking like chaotic, but actually it have unique appearance. And in those slide, and that slide in the center of the slide, you can see that some bacteria are arranged as a Chinese letters, V or some E, and scientists which are from Asian countries can say, no, it is Chinese alphabet, it is some unique letters of Chinese alphabet. So actually it is possible to find different appearances you imagine. And in some cases, bacteria arranged in parallel lines and described as a picket fence arrangement. So arrangement even is unique for Corynebacterium diphtheria, but actually if you will take a fast view, they are looking like chaotic or monobacillus in slides. So as we said in previous lectures, diphtheria is an anthroponosis, means that disease is identified only in human, and transmission is always human to human. Many species of Corynebacterium, not diphtheria of course, belong to normal flora and can be identified in the skin or respiratory tract of human, and they're usually described as diphtheroides or identified as diphtheroides. It means that it is Corynebacterium but not diphtheria, some similar in appearance. And those species will not have volutin inclusions in the cytoplasm. Corynebacterium is highly used as food in food industry because of high fermenting activity. And some species are used in productions of cheese, in yogurts, or they can be used for production of important amino acids or some enzymes. So if you talk about pathogenic Corynebacterium diphtheria in clinical practice, preferred culture media for cultivation is CNA, agar or Columbia cholesterol-adixic acid, agar containing sheep blood. According to biotypes, bacteria will have different colonies, so they will have different appearance on their culture medium. But usually there are different colors of white to dark gray, and no hemolysis is identified. So as you can see in those slides, biotypes are easy to differentiate because of general appearance. Biotype mitis, initially names of biotypes were given because of some correlation in clinical presentations. Metis means mild. Usually diseases caused by that biotype are mild to moderate, have very good outcomes, and very often occur as a simple respiratory disease. In the culture medium, biotype metis is usually white, colonies are glistering, small, as you can see in that picture in the upper right part. Biotype intermediates usually causing moderate clinical problems, clinical symptoms. And in the culture medium, colonies are as well small but dark grayish without any hemolysis around as well. Gravis means gravity, heavy. Diseases caused by that biotype are usually acute in severe state, have poor prognosis, poor outcomes. In culture medium, colonies are bigger and dark blue or dark gray in color. Belfanti is rarely identified biotype. It is the last biotype described of those four. Colonies are small to moderate in size, average in size, and again can have different colors of gray, but usually growing good and have good transparency. For identification of Corynebacterium diphtheria, usually we will use selective culture medium, which is known as Tinsdale medium or cysteine tellurate agar. It is unique culture medium which have white color, transparent consistence, and it contains different components required to stimulate the growth of Corynebacterium but inhibit the growth of most normal flora of respiratory tract bacteria. And it contains indicator for production of H2S. And usually if something is grown in that culture medium, it is Corynebacterium. And if it has black color, it is for sure Corynebacterium, because other bacteria cannot grow, or if they will grow, they will not produce H2S. That culture medium is usually available as a plate agar, and as you can see in the upper part, in the upper picture in the slide, bacteria is good growing, colonies are big and black in color as well. Agar around the colonies is not changed. For again enrichment of your sample, we have Loeffler agar, which is as well possible in plate modification, but usually we're using slant agar to enrich and to enhance the growth of bacteria to obtain bigger number of bacteria. And main unique property and the main benefit of that agar, it provides metachromatic granules of volutin growing faster and bigger. And again, if you need to differentiate pathogenic and non-pathogenic species of Corynebacterium, it is better to use Loeffler agar because bacteria will grow the inclusions faster. And in microscope on the slide, you can easily identify the pathogenic species. So the major factor of pathogenicity in Corynebacterium is diphtheria toxin. It is very unique polypeptide which is sensitive to heat and have very low, very small dose, which is lethal for human. As you can see, it is 0.1 microgram per kilo of weight. Means activity of the toxin depends on weight of the subject. As usual, biological toxin, it consists of two subunits, B binding and A is active for activity. Toxin is able to recognize the epithelium of human and invade into those cells. Fragment A, subunit A, which is active, can inhibit activity in cells, and in clinical presentation we will see necrotizing of tissues, damaged tissues. Usually again it is epithelium. But toxin can be absorbed into the blood circulation and as well, besides local activity, it has systemic effect. Usually it is described as a cardiotoxin, but as well it has neurotoxicity. And main complications of toxin systemic one is cardiomyopathy or damage of neural tissues. Unique property of that toxin, and usually it is a classic example of bacteriophage invasion in bacteria. And when we discussed some genetics, you know that it is possible to have lysogeny when genome of virus is inserted into the genome of bacteria, and bacteria can undergo phage conversion, mean obtaining new property because of that bacterial phage. And Corynebacterium is classic example because actually in native strains of Corynebacterium, that toxin is not identified. And always that gene coding toxin is provided by beta-corynephage. It is virus which can infect only Corynebacterium diphtheria, and usually virus carrying that gene. And if bacteria is toxigenic, means that it is infected with corynephage. And as well, we have some strains of Corynebacterium diphtheria. That's why one microbe can be pathogenic or non-pathogenic at the same time. If that phage is absent, bacteria have no genes coding toxin naturally, and bacteria became non-pathogenic for human. Of course, when we will talk about disease, any case of diphtheria in human is caused by Corynebacterium, which is infected with beta-corynephage. And pathogenesis is, of course, provided for toxigenic strains. So we have three major forms of diphtheria. Classic form is respiratory diphtheria, when upper respiratory tract or middle respiratory tract is affected. Rarely we have diphtheria of skin and diphtheria of eyes. And nowadays that type of disease is very rare, but previous years when major methods of non-specific prophylaxis were not available, very often doctors suffered from eyes diphtheria because during the examination of the subject they asked to open mouth, and if subject coughed or during examination some mucus can go into the eyes, then doctors became ill with that eye diphtheria. Or mothers who took care about kids, they got very close to touch some temperature, fever, just to take a look on the kid if it's fine, and when kids coughed, then eyes were damaged. Skin diphtheria usually observed only when trauma of skin, previous damage of skin is present, because bacteria cannot invade through into the epithelium of the skin in usual conditions. Later I will show you some photos and we will describe those forms. So in lecture we will describe classic form, which is respiratory diphtheria. So again, the main question, if you have a subject suffering from some respiratory disease, you can see that it is Corynebacterium diphtheria, but it can be toxigenic or non-toxigenic. And initial task for doctor is to confirm, is it dangerous Corynebacterium or not? Can it produce toxin or not? And the classic test, which is provided in any book and lectures and posters in our class, it is a ELIC test. It is type of gel precipitation when in petri dish with agar you need to add antitoxic serum or antitoxin against Corynebacterium diphtheria toxin. And in the left in A picture, it is that spherical shape white dot in the center of the petri dish that contains antitoxin, or in another modification need to use paper strip of filter paper filled in with antitoxic serum, and you need to put it in the center of agar and add clinical samples. So again, in picture A, clinical samples are seen as a prolonged oval white things on that petri dish. In picture B, it is a strip, parallel strips going through the whole petri dish. And bacteria will grow in that agar. If bacteria is toxigenic, toxin will be produced in surrounding media. It will diffuse in the agar, and some in the center marked with the yellow arrow in the middle of the zone between antitoxic serum and clinical sample. Thin semi-transparent zone of precipitation will appear. It is seen as some drawn with the pencil. And in 7 to 8 o'clock, you can see that one sample have no that strip. It means that that strain is non-toxigenic. It cannot produce toxin, marked with the 8/2. And in the B part again, if bacteria producing toxin, it will diffuse the same in the agar, but it will produce a unique X-shaped zones marked with the arrow. You can see that if it is appeared, then test is positive. And in few samples, you see that minus is present. It means that bacteria non-toxigenic because those strips are not produced. So again, it is a type of immunodiffusion or gel precipitation. Test is easy to perform, but again, it is culture medium. You need about a day to confirm a result. So in classic respiratory diphtheria, only human can act as the source of infection, but we have ill human carriers of diphtheria or some incomplete convalescence as the source of infection. Disease usually transmitted by air droplets during talking, coughing, sneezing, but in kids' age, it is possible to have elementary way of transmission when kids sharing toys, and the bacteria can be delivered through saliva or even through some common food products. Usually incubation period is about 3 to 4 days, minimum 2, maximum 7 days. And main cause of disease usually start with the common symptom of respiratory infection. Some weakness, fever, maybe difficulty of swallowing, pain in the throat, enlargement of tonsils. Later it will grow and just simple enlargement will be transformed to regional lymphadenopathy. Lymph nodes became visually big, enlarged, painful, maybe a little red and edematous. Usually kids are affected by disease and they have a lot of adipose tissue in head or in even neck. And that lymphadenopathy will be very soon complicated by edema of neck, which can be very severe. And actually in human history, we have some literature description of that disease. Younger kids have had such severe edema that skin of the neck was broken and bleeding, and even some kids that died because of obstruction of trachea with that edema, or obstruction of blood vessels because of edema, and suffered from brain insufficiency, circulatory insufficiency of the brain. Of course, if you perform examination of respiratory tract, you can easily see hyperemia and edema of throat and pharynx. And the major symptom of diphtheria is formation of pseudomembranes or pseudofilms. It is a grayish film on the surface of mucous membranes, and actually it can be identified anywhere in the respiratory tract. First of all, in oral cavity, in tonsils, in throat, uvula can be covered, and the whole soft palate can be covered with those films. And again, initially, in the very beginning of microbiology and actually the description of the disease, bacteria could invade so deep that it obstructed bronchs and trachea because of thickness of those films. And some people died because of respiratory insufficiency because of that obstruction. And nowadays, of course, it is rare because of good diagnosis and fast treatment, available treatment of the disease. So again, in nowadays, respiratory failure is rare, but we have so dangerous complication as myocardiopathy, which can lead to acute respiratory circulatory collapse and even acute heart failure. And mainly that complication is seen in adults when some immunity is already present and respiratory symptoms are non-specific and very weak. Again, rarely, but still 20 to 75% is described to manifest with neuropathies, which can lead to paralysis of soft palate, pharynx. That symptom will lead to difficulty of swallowing, difficulty of talking. Rarely, problems with eye vision and visual acuity was described. And actually even paralysis of extremity and diaphragm are described in history, but of course nowadays again it is a rare complication. So for therapy, we have two major goals. First one, to suppress bacteria itself. It will not invade in our tissues and produce a toxin. And second problem, toxin which is already produced. So always disease have 2 points. First, local presence of bacteria in the respiratory tract, which will multiply here, damage local tissues, lead to formation of pseudomembranes, and produce toxin. And second point is a toxin which is absorbed into the bloodstream and already have systemic effect. So for activation of toxin, we need to provide antitoxic serum or antitoxic antibodies. To suppress and to kill bacteria in respiratory tract, we need to prescribe antibiotics. Again, if you're not sure in the very beginning of disease, when you have no confirmation of toxigenicity of that strain, it's better to give antitoxic antibodies if required and antibiotics together simultaneously. And if later you identify that a subject was vaccinated, for example, or bacteria is non-toxigenic, then you can stop administration of antibodies and continue only with antibiotics if necessary. We have two main types of prevention of diphtheria. Non-specific is usual. It is isolation of ill person. Again, usually it is a kid's disease and you need to find source of infection first of all, because it is always human. Second, you need to identify contact kids and to check them. Are they vaccinated or not? Do they have some respiratory symptoms or not? Of course, you can take swabs to confirm that carriage is not possible in surrounding people or infection is already not present in them. But it is difficult because usually disease have some incubation period about a week, and of course in that time period kid can have a lot of contacts with other people, and it is difficult but still necessary. Of course, ill person always acting as the source of infection, it is obligatory to isolate that subject, and you need to isolate in infectious department or infectious hospital. Specific prophylaxis means use of vaccines, and later we'll talk about different modifications of toxin. The classic toxin which is used is DTP vaccine, diphtheria, tetanus, pertussis vaccine, and the component against diphtheria is formalin activated toxoid obtained from Corynebacterium diphtheria strain. Few photos of clinical presentations. That one is respiratory diphtheria. You can see that in oral cavity, it is huge production of pseudomembranes that film absorbed in one or both sides of respiratory tract and mucous membranes have actually no unique appearance, and a lot of diseases, simple respiratory diseases, can manifest by that way. If you need to confirm is it diphtheria or not, and you always will need to confirm, because of course usually a patient itself, him or herself, or parents of the kid will call the doctor because of some respiratory problems. And when you perform examination, you see that it is some film on the surface of the mucus. So the very first task for you is to differentiate, is it diphtheria? And in that case, you need to isolate subject in infectious department. You need to instruct school doctor, kindergarten doctor to check all contact people. You will need to find source of infection. Of course, it is difficult. It is kind of infectious emergency. Or it can be simple pharyngitis or simple throat infection, such as Streptococcus pyogenes. It will manifest with similar films, but of course, disease is absolutely not so dangerous, and it is not no need to isolate the subject in infectious department. You can prescribe simple antibiotics and let the kid be treated at home. So you need to put differential diagnosis as soon as possible. It's better to do it right now. And how to check? Of course, you will not have no express test or some other test, or you will not have laboratory nearby you. You will not be able to confirm microbiological diagnosis in the first even day. You need several days for that. So you can easily check quality of those pseudomembranes. Take a spatula or some, ask parents to give a spoon, or if you have nothing around, you can even use your finger, but covered with some bandage, not to have direct contact with your skin. And of course, first of all, apply gloves. Try to remove that pseudomembrane from the surface of the mucus. And if it is easily removed and it's looking like some buttery or cheesy film, when you will remove it, mucous membranes under that is not affected, maybe red and inflamed, but no bleeding, no damage of tissues. Usually it is simple pharyngitis or tonsillitis, some infection. Since the membranes produced by Corynebacterium are caused by leakage of fibrin from underlying tissues. And those membranes are very good attached to the mucous layer of epithelium of human tissues. And if you try to remove the membrane in the case of diphtheria, they will be very good stick to the surface. It's difficult to do. Sometimes even not possible. You scratching, but it's not going out. If you will remove it, then tissues will be bleeding, they will be damaged, errors, or even ulcerated, and it will be very painful for subject when you will remove those tissues. So if it is so, then it is almost always diphtheria. It is an indication for hospitalization in infectious department. It is presentation of general appearance of kit. You can see that bilateral severe edema, neck have always the same size as the head. Kids usually have open mouth because they're difficult to breathe with the nose only. They're trying to breathe with the oral cavity. And that edema is so severe, it will be very painful, and some cases even not possible to move with the head because it is painful and leading to obstruction of blood vessels or respiratory tract. So in severe cases, even by general appearance, you can suspect disease, even if the membranes are not very easily observed. Two other clinical forms of diphtheria. In the upper picture, you can see that tissues of eyelashes are affected with the same membranes, white to gray color, and the whole eye can be obstructed by those membranes. Of course, in severe cases, it will lead to serious problems with the eye visual acuity. In the lowest pictures, it is a skin diphtheria, but see the membrane is already removed. Actually, they look at the same. It is white to grayish, some membrane, nothing unique. But when we will remove that membrane, you can see that it is seriously damaged, ulcerated area, skin is damaged. You can see that underlying tissues. And in the center, also can be so deep it will even damage some muscle tissues and adipose tissues. So rare, but that type of diphtheria can be extremely painful and difficult to treat as well. So how to diagnose and prevent diphtheria properly? We have the major component of prophylaxis. It is diphtheria toxoid. It is toxin derived from Corynebacterium diphtheria toxigenic strains, inactivated by heating and formalin inoculation. It can be used for two main purposes. First of all, it is the major part of any vaccine against diphtheria, DTP included. As well, that toxoid is used to obtain antitoxic serum. It can be used for hyperimmunization of donors or horses to obtain antibodies against diphtheria toxin. So, second preparation, which is used for urgent prophylaxis or usually for treatment of severe cases of toxigenic diphtheria. It is diphtheria antitoxic serum. Classic serum is obtained from horses by hyperimmunization with diphtheria toxoid. Rarely we use human serum. It is more expensive, less available, and of course it is difficult to find volunteers who will be vaccinated, hyperimmunized with those toxoids. But still, we have that human antitoxic serum as well. Of course, serum contains antibodies. Usually the serum contains antibodies of G class. And classic way it is used for treatment of ill subjects. It will provide passive antitoxic immunity, and you need to give that serum if subject is confirmed with diphtheria and you're not sure if immunity is present or not. Was subject vaccinated or not when history of vaccination is not known. Classic vaccine, and it is one of the most known vaccines, is a DTP vaccine, which is diphtheria, tetanus, pertussis. It is triple vaccine, contain two toxoids, diphtheria toxoid and tetanus toxoid. We will talk later in further lectures. And it contains cells of killed Bordetella pertussis bacteria. In current lecture later, we will discuss that whooping cough disease and the same vaccine is used for prevention. So actually those cells of Bordetella pertussis were added as adjuvant, but of course they act as antigen as well. It is one of the most known vaccines, and initially it was invaded into schedule of vaccination at the beginning of 19th century, and it was a huge company. In the picture you can see the tram. It is USA picture from 1930, when massive info company were provided in multiple countries, and everyone was called for vaccination, because actually in human history diphtheria took a lot of lives. It was not some pandemic, not so dangerous as other diseases, but it is collective. Very often they occurred in small epidemic waves, and of course kids were the major affected groups who died because of diphtheria. And in nowadays, of course, DTP is obligate vaccination for every kid, and in human and in medical community, that vaccine is one of the most known. The main problem with that vaccine is dead or killed cells of Bordetella pertussis. It is the main allergic component, and a lot of kids can suffer from adverse events because of that vaccine, and mainly those adverse events are due to killed cell of bacteria. So we have several modifications, which is DTAP, means diphtheria tetanus toxoid, and acellular pertussis component, where an extraction of bacteria is performed and complete cells are absent, and it may making allergic property of the vaccine is not so severe. And we have TDAP. It is tetanus plus reduced dose of diphtheria toxoid and acellular reduced dose of acellular pertussis. Again, mainly it is provided for kids with severe history of allergic reactions with some concomitant allergic infections, asthma, and other. We have separate component DT, tetanus and diphtheria toxoides, which is mainly used in adult population when pertussis is not required, because usually the disease is observed only in kids up to 6 years old. So in adolescents and adults, DT vaccination is used as the main preventive measure. We have TD, which is tetanus plus reduced dose of diphtheria toxoid for those who have hypersensitivity in previous histories of vaccination with diphtheria toxoid. And we have DT, we said already about DTAP, so some photos of vaccines are presented in those pictures. Of course, not only those companies are providing vaccines, and in different countries different are available, but in common we have 5 main modifications. DTP is the main, and for additional, if some contraindications are present. Schedule is not very different in world countries, but still, India official schedule of vaccination, 3 main doses. Actually, in Russia it is the same. 3 main doses. 3 first doses are provided in 6, 10, and 14 weeks. It can be DTP vaccine, or it can be DTAP, some other vaccine if medical indications are present. First booster dose is provided in 15 to 18 months. Second booster dose is provided in 5 to 6 years. And actually, again, in adolescents, in India it is TDAP, but in Russia we're using just DT vaccine as the main vaccination schedule. So it is the vaccination of kids and adolescents. We have as well vaccination of adults, because usually immunity against diphtheria lasts for up to 10 maybe years. So in India that indication is absent. In Russia and in some other European countries we have revaccination of adults every 10 years. So it means the last dose in adolescents is provided in 10 years. So every 10 years, 20, 30, 40 revaccination with DT should be provided, especially if it is a unique profession such as laboratory workers or medical professions as doctors or nurses working in an infectious department. And nowadays we have the main problem with community. A lot of people refuse vaccination. And actually, if in previous years and previous decades we had decrease of disease because of a lot of human people, they were not susceptible to disease, and bacteria have no other options as only to infect the human. And nowadays, a lot of people refuse to perform vaccination, even in kids' age. And average rate of diphtheria in community is rising. And actually, nowadays, rare, but we have some cases when subjects with diphtheria are delivered in usual hospital in some ICU department or other because of respiratory insufficiency or cardiac insufficiency. And of course, no one will think about diphtheria because classic symptoms are absent. And only later during diagnosis or further investigation, some laryngoscopy, those sealed membranes are identified. And of course, everyone understood that the subject should be hospitalized in infectious department, but it's late because already subject is there. And a lot of doctors was in contact. So again, if you are going to work in hospitals, it's better to check your vaccination card and ask a doctor, are you vaccinated or not? It's better to perform scheduled vaccination before visiting any hospital, even if it is not infectious, if it is routine hospital, because again, subjects can be accidentally delivered here. The main question, should I be vaccinated or not? Or maybe we had cases when subject is consciousness, we cannot perform any discussions with those subjects, we do not know if subject is immune or not. We need to check immunity. If subject is sensitive to diphtheria toxin or not. We have the main test, which is a type of skin allergic test known as a sheet test. It was described and introduced into clinical practice by Hungarian pediatrician Bela Schick and named by in his honor. So the main task of the test is to determine, do subject sensitive to diphtheria toxin or not? Test is performed intradermally. You need to perform in 2 forearms. In one arm, injection of diluted diphtheria toxin is performed, and the same amount of heat inactivated toxin is injected as a control in the opposite arm. The main idea needs to be identified if immunity is present or not, but it is possible to have false results, so because of hypersensitivity to foreign proteins. And some people have allergic reaction, not because immunity is working, because it is simple non-specific hypersensitivity. So the same toxin is injected as a control for protein allergy. As a result, we can have 4 different reactions. Negative reaction when absolutely nothing appeared on the site of injection. No reaction, no redness, no pain, no swallowing, nothing. No symptom of inflammation. It means is that subject is immune. You injected toxin and toxin was very fast neutralized by immune response. Subject have immunity, and even that subject is infected with toxigenic Corynebacterium, no need to give some antitoxic serum or perform other measures of specific prevention because subject is already immune. Positive test or positive reaction. When, and actually it is shown in the picture, it is a kid's arm, forearm. Please take a look on that, and you see that redness appeared, edema, swallowing, and if you remember symptoms, 4 major symptoms of inflammation, any of the symptoms present at the site of injection is indicative for positive test. And if positive test appeared, means that in first day or up to 3 days, zone of induration appeared. It is absence of immunity, means subject is susceptible to disease. And of course, if that subject is infected with Corynebacterium, we need to continue with diphtheria serum, or if you're checking for immunity to perform or not to perform vaccination, of course, that subject is susceptible, means no immunity, you need to perform vaccination. As we said, we can have false positive reaction, where in both arms you will have the same result, some redness appear, even edema and symptoms of allergic reaction, but they appear in both arms. Means that activity is non-specific for formalin, because in second arm formalin is inactivated. It means that it is allergic reaction on foreign protein. And it's not possible really to identify if subject is immune or not, because non-specific reaction is what an allergic reaction. Uh, we cannot say if subject is immune or not, because it is always hypersensitivity will prevail. And we have combined reaction when in control arm where inactivated toxin is injected. You see pseudo reaction. It is positive, but it is positive for allergy. But in the test arm, you will see truly positive test. Means it's not some flush in duration. It is good, strong result with edema, pain, and it means the subject is susceptible, of course, and you need to perform vaccination as well. Or if it is ill person, you need to provide the subject with antitoxic diphtheria serum. So disease have very important, very high importance in routine practice, because still classic presentation is formation of pseudomembranes. But nowadays, especially in adult population, when someone was in contact with ill, we have latent cases of disease when pseudomembranes are formed in respiratory tract closer to lower region, and actually nothing is bothering the subject. But bacteria is growing, multiplying, and releasing toxin in the blood circulation. And even in our city in Smolensk, we had some cases, few cases, when healthy, strong adult man was just going to the job, then in some road he accidentally fell, and when some people came to check if it's fine or not, man was already dead. And in autopsy, it was identified that subject was not vaccinated, and actually bacteria grew in some tissues and released a lot of toxins. And people died because of myopathy, cardiomyopathy, or because of some damage of neural tissues because of acute failures of organs. So, of course, it is very important to perform vaccination, and if you have some kids, it's obligatory to vaccinate kids. And again, if you are going to work as a doctor in hospitals or even in community, some clinics or other, it's obligate for doctors to vaccinate against diphtheria before any medical practice.